I'm a physician, and I am going to speak as a physician. I think most of what I say, all of what I say, is relevant to all clinicians and healthcare practitioners. My talk is called Enhancing Clinical Performance Through Patient Engagement, Bringing Back Lessons to the Cleveland Clinic. Maybe it should be called Lessons from the McGill University Health Center and the Cleveland Clinic. So for most of my time as a physician at the Royal Victoria Hospital, I worked in nephrology. And for most of that time, not completely, but quite a lot of what I thought would be enhancing clinical performance would look something like this. This is a book of guidelines about the treatment of chronic renal failure, particularly dialysis. Okay, good. So where's the chain? Oh, the next, okay.
The green there.
The green, yeah, okay. Most of it would look like this. You know, this tells you how much dialysis somebody should have, how do you measure that, what level should you keep their hemoglobin at, blood pressure, on and on and on. Absolutely crucial. If I was being dialyzed, I would want a group who was doing exactly this. I would want these standards to be 100% met. And yet, I knew as I looked after these patients, there's much more than that going on. I remember one afternoon speaking to a Greek man, maybe in his 50s, on dialysis for quite a while. Things are not going so well. And you should know that these patients have a mortality rate the same as colon cancer, about average 5 years. So they get very sick and they do die. And you know, we weren't sure what was happening to him. Did he have an infection? But he looked like he was failing a bit, and I knew he's thinking he's failing, and I'm worried too. I looked at him and I thought, you know, this is like a heroic journey. This man is dealing with stuff I'm not sure I could deal with. He's learning stuff in the process. People are learning all kinds of wisdom here that needs to be shared. So with Sandra McCallum, the coordinator of patient volunteers, we decided to put together a book, and we'll distribute it to all of our patients, and then all of the patients in Canada, and then as many patients as we could in other settings, but also to nephrologists, nephrology nurses, and so on. And we brought out this book in 1998 in English and French. Let me just give you a little piece of one story from this book, which gives you some idea of what it's like to be faced with a very severe illness, chronic renal failure. This is the person telling the story, André Deschamps. Lovely guy, knew him well. At the time he's telling the story, he's looking back on when he first encountered kidney disease. Here's how he opens his story in the book. The spring of 1975, I was enrolled in a police technology program. I'd always dreamed of being a police officer. I would then get a law degree, and after a 20 or 35-year career, take my pension and practice law. It seemed like a really reasonably good plan. He was quite a planned character. Over the fall and winter of 1975, I had a good part-time job. A routine medical found that I had protein in my urine. I was kept on my job while further medical tests were performed. I was then referred to a local hospital. By 1976, I was diagnosed with chronic renal failure, the disease being polycystic kidneys. I knew then that the future I dreamed of would be lost. I didn't react well to that news. It was as if the rug had been pulled out from under my feet. I was stunned. I was hurt and confused enough not to realize that there were still options open to me. The question this raises is, how do you work with people like André Deschamps, who are facing this really catastrophic transition and change in their lives? Was there expertise at the McGill University Health Center in this kind of thing, in this kind of problem, this kind of challenge? There was. Balfour Mount had set up the first palliative care unit in North America, and he was at that point starting, just about the time we published the book, McGill Programs in Whole Person Care. The idea of the programs was to take the best of palliative care, what's been learned about how do you deal when your life turns absolutely upside down, and it never is more challenging or more full of loss than when you're dying. And what he had found, and others had found in their experience, this does not have to be all bad news. That in fact, in that process, people can actually find a level of well-being, a sense of connection that they hadn't found before. Programs were set up. I joined BAL a few years later, and here's the mission statement of those programs: to transform Western medicine by synergizing the power of modern biomedicine with the potential for healing of every person who seeks the help of a healthcare practitioner. So, what is healing, and how does this fit into what we do day to day? Here's a simple way that we have of looking at this and how we teach it to medical students. We say, when a patient comes to see a doctor, what's the most important thing that happens? Well, many important things, but one very important thing is the following. The disease gets separated from the patient. Is that a good thing? Absolutely. Both for what the patient wants in terms of dealing with the problem, but also for how do we decide what to do next? What are we dealing with? But it does make medicine and healthcare a very complicated procedure, or a very complicated job, because you're always dealing with two relationships at the same time. And there really are two relationships. One, the relationship with the disease, where your job is to fix, cure, eradicate. Military metaphors are appropriate, I think. The other, your relationship with the person of the patient, when your job is, we would say, to promote healing. So we would say you're both trying to cure people and fix whatever's wrong. You're also trying to promote healing. Curing is an action carried out by a healthcare practitioner to eradicate disease or correct a problem. Healing is a process leading to a greater sense of integrity or wholeness in response to injury or disease that occurs within the patient, which can be facilitated by the healthcare practitioner. It's interesting, these are not two similar jobs. These are two diametrically opposed jobs. We use the symbol of the caduceus with the two snakes, and the black and white is absolutely intentional. These really are contrasting jobs. I won't go into all of the details. Here's a table from the book Jim mentioned. But if you look down on the white snake side, contrast it with the black snake side, every situation, what's on the white is opposite to what's on the black. For instance, there is a power differential when you're trying to fix and cure, because technical expertise and knowledge does create a power differential. On the black snake side, you can't have a power differential. On the white snake side, yeah, things need to be standardized. On the black snake side, you can't standardize your relationship with an individual person, and so on and so forth. The good news is people can do both of these jobs at the same time, and the best news, they really do synergize. We've been teaching this to medical students at McGill for the past about 7-8 years. We're teaching it in all 4 years. Mark Smilovich, who's here, he and I are very much involved in this teaching. Stephen Lieben, I don't think is here, is also joined us in doing this teaching. So I won't go through this at too great a length, but first year we teach 5 sessions where we're trying to lay out for students, what is medicine about? What is this? What is healing? How does that fit into, why you're a doctor? Do medical students take to this? Absolutely. In fact, it's a bit like the previous speaker talked about. This is probably why they got called to medicine in the first place. In the second year, we teach a mindful medical practice course, which is very much to do with how do you stay present to somebody in a relationship, which is a very deep and powerful relationship, and various aspects of that. In third year, various things, but we take students to the simulation center, and have them actually interact with actors who are putting them under huge pressure. And can they stay centered? Can they stay present? Can they engage themselves in a relationship which would be helpful to a person who's under pressure? Fourth year, then we mostly a tie-up, trying to get this, and we hope more in the new curriculum to transition to clerkship. So where does the Cleveland Clinic come in? Let me just take a brief drink of water, sorry. So what do our students tell us? Very much like Angela had mentioned, they tell us, Dr. Hutchinson, Dr. Smilovich, this is great, we're totally for it. It makes so much sense. How come when we go to the hospital, this is not what people are doing? In fact, they're actively discouraging us from doing this. So the Cleveland Clinic appear, and I'm not sure how much they've succeeded. They've succeeded to some extent in changing the culture in a way that makes it more open and conducive to what we're talking about. They teach a course called the READY, Relationship, Establishment, Development, Engagement, maybe the other way around. And we decided to go to the Cleveland Clinic, see what this course is like, and we participated in a one-day course with about 8 people from the Cleveland Clinic and some other visitors in us. Very well taught course. They've taught it to about 4,000 physicians and physician assistants. I'm not going to go through the whole course, but what's the bottom line of what I learned from that course? And I would say it's the following. This is just their model, but I would say if you look at it in terms of our 2 therapeutic relationships, what the Cleveland Clinic are saying is the following. Not only do you need both of these relationships, but they would say, the most important relationship is the relationship with the person of the patient. That's what you've got to hold on to. That's what you've got to make sure is working. And I would say that's exactly the shift that we need to see in medicine, because for too long we've thought the important relationship is the relationship with the disease. We've got to do a good technical job. What kind of things follow from this? Well, for me, at least 3 things, probably more. First, engagement. We talk, and we are talking appropriately about patient engagement. But my experience is that in a one-to-one relationship, and I understand this is just a simple model, there are many one-to-one relationships and there's a whole context. Patients are not hard to engage. In fact, most patients are extremely keen to be engaged. They're totally emotionally present. They're absolutely there as persons. Who's not present in that relationship? Who needs to be engaged? Mostly the doctor and the other healthcare practitioners. So the first part of this is when we're talking about relationship-centered care, the engagement we need is from both those people. And I think we need to create context, support, nurturance for the healthcare practitioners so that they are able to participate in this relationship. One point. Second point is there is a balance here. Both parties benefit from this relationship, as they should. And we should be designing a system that is self-nurturing in the sense that if it's really working, healthcare practitioners should be getting out of this satisfaction, reward, in personal reward that makes their life and their work self-sustaining. Malcolm Mount says, healing begets healing. If healing's happening in the patient, healing is also going to be happening in the healthcare practitioner. Now, doesn't this sound like a bit different than patient-centered care? I thought the patient was the center of all this, and they are. And I would say what we need to distinguish is between the purpose and the process. The purpose is definitely patient-centered. This is not designing a hospital so doctors and nurses will be happy. No, But in order to put the patient at the center and give the patient what they need, the people working in that institution have to be enjoying their work, getting rewards from it, having support that makes this possible. Okay. Is this possible? Absolutely. Let me finish with a story of a patient that I met a year ago. Very difficult situation. Here he is. He's given me permission, he and his wife have given me permission to tell the story, use it in any way that would be helpful. His name is Mr. Kuznetsov, and his wife, subsequently his wife, is Dale Montour. So Mr. Kuznetsov came to the Royal Victoria Hospital. He had lung cancer, advanced so that he couldn't have chemotherapy. He also had a very severe complication of his lung cancer with coagulation of everything, not just veins but arteries, which meant that the arteries to his legs were blocked. He had bilateral ischemic feet which were turning gangrenous and terrible pain as a result. So he had to be put on full-dose heparin to prevent him clotting everything else. And we were called from palliative care, can we help his pain? So this kind of pain responds well to things that treat neuropathic pain. And we struggled, but we were able to control his pain. What I want to talk about is what happened over the next 3 to 4 months. We visited him every day. Increasingly, we visit him at the same time every day because we know that his wife came in and they would be waiting for us to say, what's happening, what's the update today? And those conversations would have 3 elements. The first element would be, how's his pain? And it might be, how's his delirium? Because every so often we'd go over the edge and he'd become confused. So we'd have to fiddle around with his methadone and his some more other medications and try and get that right. So that was the first aspect, which is more a fixing, curing aspect. The second was, well, where does he go and what happens next? That was a big struggle because he's on a surgical floor, 9 East, I think, 9 East, yeah, at the Royal Vic. Surgery doesn't think that's a good use for that bed. People are saying he should go to palliative care. Where should he go? We thought, yes, maybe he should go to palliative care. His wife visited the palliative care unit. She hated it. She said, that place drives me crazy. It's so still, it feels like death. He cannot go there. So we ended up staying at on 9 East, and the team there really got around. The nurses became involved in a big way, personally, and that really worked. What's the third part? The third part is us getting to know him as he wanted us to get to know him. So we would always sit down, we'd fix what could be fixed, we'd hear about if there was discussion about what happens next, and then he would tell us about his life. And he had an interesting life. He's Russian. He'd grown up in Russia before it all changed. He wanted to get out. He decided he and his friends would buy a gun, and they would hijack an airplane, and they would fly to the West. Luckily or unluckily, the KGB are very good at their job. They caught him, and they sent him to Siberia. What was the experience in Siberia like? Not bad. Not bad, he said, because there were an awful lot of wise people in Siberia at that point, and he had more education and mentorship in that period of his life than any other. He subsequently escaped. He became a filmmaker, which is how he found his wife. The changes that occurred in Mr. Kuznetsov, we didn't produce those changes. Probably we didn't get in the way. And I think our relationship with him, and it wasn't just me, Suzanne Bless, the other palliative care doctors, but it was helpful, I think. It was supportive of a process that was really happening. And that process was really healing, I would say. Because what you saw happening was, and Mrs. Dale said that, their relationship deepened. She said, we always had a good relationship, but our relationship in the last few months are deeper than they ever were. And he, in a way that I really couldn't comprehend, in the sense I couldn't imagine myself getting there, he became more peaceful, more of a sense of humor too, and you could see him growing. I really think that he grew more in those months probably than he had for quite a while. They got married on 9 East, in a room at the 9 East. It was a beautiful marriage, small. She was Mohawk, and her Mohawk relatives came. We attended the wedding. He died, as we knew he would. He died when I was away in Japan. And when I came back, we met with her, and she gave us a beautiful thing, a Mohawk thing for doing the smudging ceremony. She said, I'm giving you this because this is what you guys are about, healing. And we hadn't mentioned the word. What's the point? The point is, I think this healing process is a very important part of what we do. It's crucial for patients dealing with serious problems, and it's crucial for us as healthcare practitioners, because that's the reward of being a healthcare practitioner. Did I go away from this experience kind of worn out, feeling I never want to do it again, burnt out? Exactly the opposite. Energized, feeling this is exactly what our work is about. So let me conclude. I think people with serious illness want and need the best technical care available, and so they should, and we should not talk at all about downplaying that. Everybody wants the best possible, no question. Helping people with serious illness requires more than technical expertise. We need to establish a relationship that is healing for both parties. This combination of curing and healing, which is whole person care, I believe, is the key to individual patient engagement and, I think, excellent care. Ladies and gentlemen, thank you for your attention.